Afternoon, James. We should be ready to start whenever you are.
Thanks, Rowan. Good afternoon, everyone. My name's James Goodyear. I'm the Director of Strategy here at Leeds Teaching Hospitals. Welcome to this week's Report Out. We've got a busy agenda with three presentations, so we'll get straight into the first presentation from Melanie, Claire and Nadine in the transfer team 30-day report out.
Morning everyone. I think Claire's just going to share our slides. Here we are. Okay, so welcome to our 30-day report out for the transfer team Kaizen event involving facilities, site team, urgent care and sim patient flow. This was a Kaizen event aimed to reduce waiting time in ED and improve patient flow within sim and urgent care. So the problem framed by our sponsors was long waits for patients in ED from being TCI'd to being admitted to a bed space within sim and urgent care. The burden of work seemed to be focused on the creating capacity process step, leading to waste within our process boundaries, and we wanted to improve communication and processes between departments to reduce waste and improve steps in our process. We also wanted to reduce the occurrence of batch cleaning, where wards and departments logged multiple bed cleans at 2 p.m, causing delays in cleaning bed spaces and getting patients into those bed spaces. So actions from our Kaizen event, we came up with 5 PDSAs. So one of those PDSAs was for ED to attend the bed meeting for improved communication between departments and CSUs. We wanted to improve the sim bed report to reduce duplication and avoid unnecessary emails. We also wanted to improve awareness of patient transport options to reduce batching to one provider, causing delays and long waits for patients when going home. We also wanted to implement a transfer team to more effectively use staff time by completing full cycles of patient transfers and bed moves by patient flow team, teaming up with a porter to complete all moves within the CSU and bring patients up from ED in a more timely fashion. Our last PDSA was around batch cleaning, whereby the hub facilities hub would inform the site team and wards where batch cleaning was occurring.
Hi, I'm Claire Place. I was the team leader on this event. So we have 5 outcome measures that were measured on our TPR. So the lead time was the decision to TCI to the patient arriving on the ward, and this is improved by 26% at our 30-day report. Our sub-lead time was the job being put on carts to then the patient arriving on the ward, and we've improved that by 44%. Although it's not measured on our TPR, I just wanted to comment on, we've also been measuring the impacts to the greater portering service. So we've been measuring, trying to reduce the use of porters across. So for example, one cycle of work for the transfer team in moving 3 patients has not only reduced that sub-lead time to the patient arriving, but also saves 5 porters, which leaves them available to be able to support other services across a trust, including radiology. We've measured a defect in our systems was the bed being left empty for a prolonged period of time. Initially, our first report out, we did see an improvement of that of 33%. And although that's moved, we're still seeing improvement, but only at 3%. There's some variability in there, and we're hoping to improve that over the next 30 days. Staff feedback has improved at 52%. We're getting a 100% rate of 5 or above for our feedback. Patient feedback we have tried to capture, but has been quite a challenge due to the demographic of the patients that we're moving, but we're hoping to improve this as we continue to trial our PDSAs. What went well? So this is some of the feedback that we've got during our staff feedback. But for us, building working relationships has been a positive. Working with other departments has allowed us to have a greater awareness of each other's roles, be more sympathetic to the conflicting pressures that we're all working under. We've improved communication, especially around the ED teams and other patient flow coordinators and the CSMs. CARPS have worked really well with us, allowing the transfer team option to be available to sim CSU to deploy when they need, and that's had a really positive impact and has led to the users of this system having more confidence. They've used it overnight recently when flipping bays, and it's demonstrated a real-time saving for them. Positive feedback from the porters as well about working more efficiently in one area, and we've managed to maintain engagement and momentum of this team that we've worked with. What would we do differently in next steps? So although I've just mentioned communication being positive in some areas, especially with ED, we could have improved on communication to the wider ward teams and the portering teams that were involved in this. Some were not aware of, especially the transfer team, which was impacting their work. So I think increasing that communication and potentially using different avenues to do that. Initially, we did it through verbal updates. However, we probably could have used other communication methods. Next step that we need to look at is some job roles and responsibilities with our DCN sponsor, especially regarding the patient flow coordinators. We've got some training sessions booked in for the staff to understand about the transfer options, what's available and how to access them. And then what we really want to move on to is making, especially the transfer team and ED patient flows going to the bed meetings as business as usual. So we're hoping that going into the next 30 days, this will be our usual business and then we can measure it effectively. Thank you.
Fantastic. Thank you, guys. Brilliant to see the progress. And I'm sure we'll save questions till we've seen all the presentations, but I've certainly got a couple of questions for you. Thank you so much. So we'll move straight on and hear from Katie, who's been working to improve postnatal care with the community midwifery team. Katie.
Hi, I'm Katie Cavell. I'm one of the community midwifery team leaders, and this is our plan to improve postnatal care. And this is just an overview of our presentation. So our plan to improve postnatal care was because the largest number of complaints and day text themes that team leaders received in community was regarding missed postnatal visits. And it was also families and midwives' dissatisfaction with the quality of the care that they were providing or being provided with. Therefore, we recognise that the main area to develop was reviewing current working templates to maximise efficiency of workload whilst taking into consideration staff safety and morale. And this links to two of the Trust 7 commitments, being staff retention and finance. Therefore, we initiated a quality improvement initiative by firstly appointing a midwife to lead on the postnatal care pilot and developing a plan with interventions to help solve the problems that were raised. So this is a cycle of improvement. So we recognised that staff had low morale, there was poor staff retention, people leaving, and high sickness rates. So we needed to look at ways to improve their daily working schedule. So we looked at clinic templates and reviewed those and adjusted those to become more time efficient, with protected time for admin and allocated time for postnatal visits around lunchtime as opposed to the end of the day. So midwives work in busy clinics all day and then we're going out and doing visits at the end of the day. So we revised all that so they were doing them in the middle of the day. This obviously improved staff safety because they were going out in daylight visiting hours, obviously in the winter months. And obviously more senior staff were around for concerns to be escalated to, and other support such as community midwives, we do a lot of safeguarding work. So safeguarding support is available more freely in the middle of the day, especially sort of social care work, sort of 9 till 4, 5. So it just made sense to move them into the middle of the day. And this improved cross-city working as well between our teams. And it was a much more fair distribution of workload as well. So that in turn, then obviously we're hoping improved staff morale and retention. So just acknowledging some of the Trust 7 commitments, staff retention being the biggest commitment to this pilot. Staff have reacted very positively to the changes in our survey. I'll discuss those results in a second. And we're definitely seeing a huge improvement in staff willing to help other teams with their visits now that they can do them earlier in the day. And we're prioritising staff safety as well, as I've just spoke about, and obviously hopefully achieving the gold standard postnatal care. Finance is also a commitment to this process, as we're not requiring as many midwives to work overtime to ensure that they were getting their visits and admin done. And waste reduction, we're also maximising our clinic space to ensure women get the appropriate appointments, and there is allocated time for midwives to complete all their admin in the working hours, ensuring that we're time efficient and gaining the maximum productivity. These are a couple of templates. So there's an old template and a revised template. So a midwife working 8/6 in community will now come in speak to a team, acknowledge your visits for the day, and then get cracking in a clinic, which usually is held in a GP surgery or in a health centre, children's centre. Those appointments will run up to about 11 o'clock, and then she'll have that visit time to go to postnatal visits in the community and have a lunch, possibly a bit of admin time in there, but generally just visits and lunch, and then come back in the afternoon to a clinic, see more women in their appointment slots, and then have some time at the end for admin. As you can see, the previous template was they did their visits at the end of the day. So we sent out a staff survey on attitudes to the postnatal care pilot and how it's going. And the results speak for themselves, really. 84% thought that the postnatal care pilot had improved their work-life balance. 88% thought the new way of working encouraged them to offer help to other teams. 88% felt safer doing home visits in the middle of the day rather than the end of the day. And 78% felt scheduling the postnatal appointments in advance helped improve their workload. These are some figures showing the improvements from 2023 to 2024. Actually, it starts in December 2022, but we have priority visit days. So first day out, day 3, day 5. So this is some figures showing day 5 visits. So back in December 2022, 57 women got a day 5 visit, as opposed to December 2023 when we started the pilot in November 2023. And so, yeah, as you can see there, it's 97%. So a significant rise in those women getting that appointment on the day that they should. The figures here and to the right are, once we've finished our care in community, we transfer to a health visitor, and there's a notification process that we need to follow. So in April 2023, 58 women were missed being appropriately transferred to the health visitor, as opposed to, as you can see there, in May 2024, only 3 were missed. So this whole pilot has definitely created some huge improvements. So we do auditing to ensure an inflow check. We do daily audits run by our K2 system, which is what community midwives use, the system they use, and it identifies missed scheduled postnatal appointments on the key appointment days that I've already mentioned. So first day out of hospital, day 3 feeding support, and day 5 for that screening and appointment and postnatal check. And we also run a weekly report on the transfer to health visitor now as well. The running of these reports ensures visits and appointments are not missed and that care is offered as scheduled or as near to the time as possible. Whereas in days gone by, it could be a week, it could be longer, until we detected somebody had been missed. So summary and next steps. Although our pilot is ongoing and the benefits of working in this revised way are already very evident, a more structured way of working with protected time for administration has increased patient and midwives' positive experience. And we know this through the reduction in PALs that we receive and DATEX and the audit figures compared from last year to this. The introduction of our daily auditing process is a mistake-proving step, which ensures the early detection of missed opportunities for postnatal care. And the adjustments have been made to improve staff morale and efficiency of our service. And it's also aided in waste reduction by maximising productivity and clinic space. And we feel this pilot has been very successful so far, and it's transformed the way we work in community. Going forward, we hope to continue working in this way with the auditing process in place to support the evidence of these improvements to our service and staff. Thank you.
Wonderful. Thank you, Katie. So impressive and just really inspiring to see that the changes you've made have been good for patients, good for your staff, and also contribute to us using our resources effectively. So really, really well done. So we'll keep going and come to questions at the end. So if I can invite Adam to present to us next, who's going to be telling us about work to ensure responsible environmental engagement with nitrous oxide use in dentistry. Adam.
So hi, my name's Adam Jones. I'm a oral surgeon in the Dental Institute, and I'm here to report on our nitrous oxide engagement project, which is a quality improvement project I ran alongside my Leeds Improvement Method training earlier this year. So the aim of this project really is to assess the carbon footprint of the nitrous oxide that we use in the LDI, and then to look at identifying some steps to reduce the impact that our sedation service using nitrous oxide has on the environment. So the problem that we have in the LDI is that we use a lot of nitrous oxide, and it's a really effective way of managing people that are anxious about dental treatment, but it's got a really disproportionate climate impact. So nitrous oxide is a gas which is about 300 times worse than carbon dioxide for the environment. Lots of other areas you might have come across reducing their gas usage, such as anaesthetics. These specialties have another gas that they can use. Unfortunately for dentistry, we don't have anything that is as safe and as effective. So our goal really is to kind of optimize our use of it. So to start this project off, what we did was an investigation into how much nitrous oxide we're buying at the LDI. So that's 80,000 litres a year, which is a not insignificant amount. That's equivalent to about 2,500 cars being driven for a year, 1,500 homes energy use. And if we wanted to mitigate that climate impact, we'd need to grow nearly 200,000 trees for 10 years to balance out our yearly gas usage. So the first step of this project really was to look at our processes and our delivery of the gas and identify areas for wastage. And the pie chart here shows that we could account for about 80% of the gas that we used, which is actually pretty good to only have 20% gas loss. In a lot of other settings, some of the nitrous oxide loss is up to 90% before it reaches the patient lungs. So our 20%, although it's a significant amount, is not too bad, and it's that gas loss as part of the system isn't necessarily something that we can impact quickly. So we chose to focus on the 80% that we use and how we might be able to optimize our use of that gas. So what we did was engage with the teams that are using the gas and observe the processes and tried to implement just some really non-invasive and simple techniques to improve make that process more lean, as it were. So the first thing that we did was introduce a discussion about climate impact, or at least a notification of climate impact into our pre-op brief. So whenever we're about to sedate someone, we have a pre-op checklist to run through, and a non-invasive addition to that list was to agree a signal between the clinician doing the treatment and the nurse who's doing the observations and assisting, to think about when the gas might be able to be turned up or turned down or turned off. Because one of the things that we came across in our audit was that often we were titrating the gas up quite nicely till the patient was relaxed, but then it would remain at that same level for the whole procedure, and that could be 20 minutes, it could be 90 minutes. And actually what we know from the clinical observations is that people are often anxious about a particular part of the procedure. So maybe that's given the local anaesthetic, and we're able to titrate that down once they've been given the anaesthetic and they're numb while we carry out the rest of their treatment. And what we noticed was that clinicians were so focused on their actual doing the clinical process that they forgot about the gas. So this pre-op brief just gave a bit of awareness, and it also sort of empowered the rest of the team to give the clinician a nudge and say, hang on, this patient looks nice and relaxed, can we turn this down now? The other arm of our training really was to run an awareness campaign. So lots of staff delivering nitrous oxide in dentistry, myself included, thought that it was a free gas really, and there were no downsides to using it. The environmental impact wasn't broadly known within dentistry at the time. So we did some lunch and learns, and we integrated training on sustainability into both our undergraduate curriculum through my role with the university, and in our postgraduate training of registrars as well. So we had this three-armed approach of engaging with the nurses and support staff and the different grades of clinicians that were carrying out the work. And then we looked at technical factors for how we deliver it and how we might be able to reduce the volumes of gas that we're using. So we have a really efficient scavenging system which draws the nitrous oxide away from the patient and the clinician. but sometimes that volume of suction can be too high, which wastes gas. So we did some training on how we can safely reduce that volume. And then we introduced this concept of the Goldilocks principle related to this inflation of the reservoir bag. So too flat, it means there isn't a sufficient reservoir in that left picture. The central picture here is overinflated and we're wasting gas. And then the picture on the right there is about right. So we've used this series of images a lot in our training and awareness as a visual aid memoir. So in terms of outcomes, we've only really just getting to the end of rolling out our training to all of the it's a large service in the LDI, so we haven't got around to rechecking our gas usage. That's a January 2025 job. But what we have done is looked at the data that we've got and compared it to a national audit project, which was started up while we were undertaking our project. And we've taken lessons from other units and applied them into our own systems. And then we're going to re-audit that gas check next month. So in terms of what went well, the project was actually really well received. So it was reported as quite an empowering project for people. So these two cycles on the screen here are two common cycles that people fall into when they're talking about climate change interventions. And one approach is that there's nothing we can do, it's a really big issue, and you fall into this despair spiral. And actually people reported that being made aware of the big impact that they could have through their healthcare work rather than just small interventions at home has actually helped staff to feel more positively about the role that they can play in climate change, and also to think about how they can apply the same thinking to their own practice in different ways as well, and make that societal contribution. And then enthusiasm for making the changes was really high. So I think that was key to the success of the project, is that we consulted with the staff on the ground and asked them for changes. So the pre-op brief idea didn't come from the auditing team, the quality improvement core team. That was a suggestion by the clinicians and nurses to make it, and that's been the key thing that's made a big difference, really. I think in terms of what we would do differently, there's very little really. It's gone very well. I think one of the things that we'd like to do is engage with the medical gas suppliers with that, about that final 20%, because what we think is that 20% of gas is left in the bottles, which are then returned to BOC and then vented to the environment without any processing. So that's one of the next steps. And key learning for us really was around empowering staff to take responsibility and to get involved and to make small changes which have a big impact. So adding just a one line to the brief has had more impact than we could have envisaged, really. And then next steps for this project. So again, through my role with the university, what we're actually working on now is a device to process nitrous oxide after it's been exhaled, so that we're catalyzing it or collecting and recycling it. So we're engaging with the chemical engineering and the medical engineering departments to and a local equipment provider actually that provides the national nitrous oxide delivery equipment to dentistry, and those two partners are joining us to make a medical device which should help us manage the 80% and the 20% that's lost as well. And then there are some other QI projects that have kind of sprung out of this, but I think necessarily haven't got time to talk about those just now. But I'd be happy to take any questions. Thank you.
Fantastic, Adam. Thank you so much. Really inspiring to see the way that you've empowered colleagues to be able to take action against what is a global issue, but one that we can influence through our practice. I really like the kind of nudge at the pre-op brief. Really interesting to hear that came from the staff and that it's been felt to be effective. I hope you'll come back to report out to tell us about the results of the audit once you've re-audited the gases. So thank you. So 3 great presentations and very much in contribution to some of our 7 commitments around reducing waits for patients. improving staff retention and delivering greener care that contributes to environmental sustainability. So we've now got an opportunity for comments and questions. So would anyone like to come in? If not, I will start. So Mel, Claire, Nadine, thank you. Really interesting to see the progress and some fantastic results in terms of improved flow and reducing weights. You mentioned one of the metrics where you'd seen an initial improvement, but it had slipped back a bit, was around the time taken to return an empty bed. So I wondered what your thoughts are on kind of future PDSAs to try and see a change in that prior to your 60-day report out.
Thanks, James. I'll come in there. Part of the delay is the cleaning of the bed space. So what we've talked about in the transfer team option is utilising the porter-ins that have skills that can clean beds at the same time. So whilst the patient flow is managing with the patient, they could be then cleaning the bed, and that will delay some of the time that's taken, because a lot of the delays we find is awaiting someone to be available on the ward to then clean that bed. So that'll be in the next PDSAs, utilising those facilities a bit better for what we've got resources wise.
Fantastic, thank you. Denise?
Have you found that the reduction in WEP toward environment porters has led to further delays in bed cleaning?
We haven't really measured it today, so I'd like to say, but I'd say anecdotally from the wards that was something that we found in the Kaizen event around the batch cleaning, is that the WEPs are not available on the ward, so therefore the housekeepers are busy doing their jobs, and we have found in some of the data over meal times, and there's a bit more of a delay for that bed to be cleaned.
Interesting.
I'll just come back in there, Claire, as well, and just add to that. On a morning when from 6 o'clock till 10 o'clock, while the domestic staff are doing their meal service as well, there is a long delay there. So the people that have been up waiting overnight as well, if they haven't got the WEPs, that is causing a delay there as well.
Okay, thank you guys. Katie, with regards to the work that you've been doing, I thought what was really impressive was the increase in the number of patients getting their day 5 appointment, which was really fantastic to see. And I love that this work has come from both the complaints that you were getting from patients and families, and also staff's dissatisfaction. I wondered, as part of your kind of ongoing evaluation, obviously you can monitor your number of complaints and day ticks. I wondered whether you'd had any qualitative feedback from any of the patients that you're supporting.
We haven't.
Is that something you might think about?
We definitely think about, yeah. So we're aiming to review all the data in December. And then we'll look at that then. Okay. Yeah.
Great. Fantastic. And Adam, really brilliant presentation, and really interesting to see the opportunities for collaboration with the university, and the way that you've used your role to influence the dental training programme to bring these issues to life for colleagues earlier in their careers and help motivate them. Yeah, really a unique opportunity, given the kind of role of the dental school, as well as the Dental Institute. So thank you. So I can't see anyone else's hand up, and we're at just at 1 o'clock. So fantastic presentations, guys. Thank you for sharing them with us. Please do, as you continue with this work, please do come back and let us know how you're getting on at a future report out, and have a fantastic Friday. Take care.